Welcome back, Health Impact audience. We've got a great next hour for you talking about a wonderful set of tools and technologies that the National Institutes of Health, many of you know them as NIH, has been working on specifically to help hospitals and health systems with rapid and accurate assessment and treatment of COVID-19 using machine learning tools. So our two guests come to us from the National Institutes of Health, National Institute of Biomedical Imaging and Bioengineering, what is referred to as NIBIB. The National Institutes of Health, as many of you know, are a group of institutes. So like, for example, National Cancer Institute, and there are molecular biology institutes, there are brain institutes. But what we have here are two guests, Dr. Going Liu and Dr. Krishna Kandarpa, who are going to talk about this new MIDRC, the Medical Imaging and Data Resource Toolkit. They're going to help give us, as the audience, a little bit of overview on what it is, and how it works. And remember that during this talk, you can ask them questions and they'll be responding magically while they're talking. So please do ask questions, because these kinds of toolkits are very important because they're more than thought leadership. They're just not general ideas about how to do things, but they're really technologies and capabilities that you can start to use today within your institutions. So I'm going to introduce both of our speakers, and Dr. Krishna is going to take over first, and he's the Director of Research Sciences and Strategic Direction at the NIBIB, at the NIH, and he's a cardiovascular and interventional radiologist. So imaging has been part of his life for decades. So this is a person working day to day in addition to what he's doing now at NIH. So he's got a lot of experience and expertise. Ask questions as they come up. So he's been a tenured professor and chair of Department of Radiology at University of Massachusetts Medical School and radiologist in chief at the UMass Memorial Medical Center as well. So he's got a lot of scientific background and clinical background. Dr. Going Liu, she's the program director of Applied Sciences, Applied Science and Technology and Bioimaging at NIBIB. She's the director of the MRI program at the NIBIB, and she's going to talk to us about the specifics. And so Chris is going to help introduce us. Going is going to then walk into a little bit of the details, and they'll give us a little bit of background on themselves as they go through where they feel it's necessary.
Thank you, Shahid. So this is a two-part talk on how MIDRC, Medical Imaging and Data Resource Center, got started. It was actually an urgent response to the COVID-19 pandemic. I'll give you a general overview, and then Going will go into the specific goals and scientific structure. Now, it all started out of the Obama White House in 2015 when the National Science and Technology Council, the Committee on Science, led by Dr. Collins, our director at NIH, Dr. Cordova at NSF, and Dr. Kratsios at the Office of Science and Technology Policy at the White House. They convened an interagency working group on medical imaging, which was actually chaired by Dr. Rod Pettigrew, who was the then director of NIBIB, and Richard Kavanaugh from NIST. Now, these were all the agencies. It might surprise you how there are so many people, so many agencies, but every one of them has an interest in imaging of one sort or the other. For example, medicine uses a lot of NASA algorithms for imaging. We also invited, to make it a true public-private forum, we invited leading medical imaging community and organizations, and also several industry partners, industry members, I should say. The theme of the interagency group was to advance high-value medical imaging. That included data standardization, advanced computation and machine learning, which is the focus of the rest of this talk, high-value imaging, and best practices in medicine. In 2017, the December of 2017, finally a roadmap was published, which is now in the Federal Register, and of the work of this group. And the one key takeaway that is relevant here is to establish a public-private forum to coordinate efforts and interests in the artificial intelligence and medical imaging communities. So we had our first workshop in August of 2018 as a very quick follow-up on artificial intelligence in medical imaging. The purpose was to just see what was going on out there and what the needs were. Subsequently, the groups who participated in this workshop, which included government as well, other agencies, and of course, many NIH ICs, we call them, or centers. And they came out with two publications, one on the foundational aspects of the research in artificial intelligence and medical imaging, which came out in Radiology, and this one in the Journal of American College of Radiology, which actually won an award that year on the translation aspects of AI in medical imaging. Coincidentally, a few months later, Congress was in total alignment in that in a document pertaining to the NIH Common Fund, they recognized an insufficiency of platform technologies and the inadequacy of physical sciences input towards emerging unmet medical needs in medicine. And they specifically cited not only the Common Fund, because that's what the document was about, but also NIBIB in particular, of all of the institutes of the NIH. So clearly we were sort of ahead of in this. We had already in November 2019, that's not even a year ago actually, had another workshop on accelerating clinical adoption of medical intelligence applications in medical imaging. And all of these institutes, all of these additional internal and external government entities also participated, and the critical gaps that were recognized between the two workshops, and incidentally, there were other parallel workshops going on with the Academy of Radiology Research and NIST, RSNA, and AAPM, but the consensus was that there were some critical gaps, one being the absence of large and diverse medical image data sets, like an ImageNet, if you will, a medical ImageNet, a need to integrate siloed databases and knowledge bases, a need to develop non-redundant, efficient AI tools, and a need to create an ecosystem of stakeholders to develop clinically validated AI applications that improve patient management and clinical outcomes. And the implication there is that these will not be available unless they're commercially available. So really what we're trying to go, this is shown schematically by Dr. Lorsch, who's the director of NIGMS. It shows us going from siloed databases and et cetera, as I said, to one integrated entity. At the same time, a multi-society statement, including Europe and America, came up with the statement that the clinical imaging community lacks dynamic, secure network systems that provide an ethical framework to help steer technological development, influence how different stakeholders respond to and use AI, and implement these tools to make the best decisions for and increasingly with patients. So it looks like there was an alignment here of not only national but international interests. So the maturing consensus by then, by November of 2019, was that we needed a central state-of-the-art resource to accelerate real-world clinical applications. The reason, improve patient management and strategies and outcomes. And the way we were going to do it is pick one or two high-impact clinical use cases using imaging primarily as a nidus, but supplementing it with all clinical associated clinical data, much like radiologists do in the reading room. Many of these images are not read in the vacuum. And in the process of doing this, applying AI, we would reveal in-depth beginning to end effects of disease and interventions. This is very consistent with NIBIB's mission, which is to engineer the future of health. So by December of 2019, the search for the ideal or high-impact clinical use case was on. We were talking about all kinds of things. And lo and behold, in January, we had SARS-CoV-19 SARS-2 appear in the United States, which you are all probably sickened to death by now. This just shows the ground glass opacities on a dual energy CT scanner, but we also know that there are additional complications such as thrombi DVT and pulmonary emboli, as shown here. And of course, the treatment for at pulmonary embolized heparin. And here is a study out of Italy that shows an increase in the rate of bleeding from the use of heparin. And I only show this to you because this actually illustrates the modus operandi of the havoc that the virus creates, leaky blood vessels, inflammation, which play out clinically in the lungs and in the heart. So quickly following, we NIBIB started considering COVID-19 as a viable use case for the particular data and machine learning resource that we were deliberating on. And then very quickly, we developed and released a request for proposal and a statement of work for Medical Imaging and Data Resource Center, which we call MIDRC, to urgently respond to the COVID-19 pandemic. And by July 2020, we received a responsive document from a consortium of leading medical imaging organizations, as shown here. And I will have another slide which will elaborate a bit more. These are the actual players, if you will, who wrote the proposal. Mary Ellen Geiger from the University of Chicago and associated with the Association of American Physicists in Medicine, Paul Kinahan, Etta Pisano from ACR, and Mike Tilkin, Kurt Langloss from the RSNA, and Adam Flanders. And then we had two advisors who helped write the document and develop it, but are not part of the future MIDRC per se, except in some collaborative projects, perhaps. And Dan Sullivan, who was at the NCI, and Mick Schnall, who's now is a chair at UPenn, a chair of radiology at UPenn, and also the chief at the Academy of Radiology and Biomedical Imaging Research. And we really thank them for the very hard work they put in. They agreed that COVID-19 represents an urgent high-impact use case for which patient outcomes can be improved by supplementing medical imaging with adjunct clinical data and applying machine intelligence to reveal beginning to end effects of the disease and interventions, which is basically language that was from those publications. Now, the importance of this is that it's a multidisciplinary, multi-institutional partnership spearheaded by leaders in the medical imaging community. Their collective extensive experience with DICOM-based medical imaging, which provides unique, definitive, and quantitative information on affected organs, is very important to get MIDRC on its feet. And the associated clinical data, often of less complexity, is easily assimilated. Now, the immediate goals of MIDRC are to accelerate knowledge and innovation and to empower population-wide preventive and management strategies for COVID-19. I will come back to that. They will initially work with the NCI's Cancer Imaging Archive, later, which is a mature 15-year-old archive at least, later moving on to Gen 3 at the University of Chicago. They will definitely include additional image and non-imaging data feeds very soon, and try to connect with multiple registries and repositories that already exist in the country, and will develop new diagnostic tools, including machine learning tools. Now, as you know, AI, has clear roles in image acquisition and processing and workflow. There's controversy over interpretation. To what extent will it get involved with the radiologist? But I think in terms of population-wide research, it would be very useful. For example, you can have a lot of secondary findings that are immediately don't seem urgent, but can play into the ultimate prognosis of the patient, or even treatment interventions and how they may be followed on imaging, for instance. So the expected immediate impact is that it will corroborate detection. A lot of people are doing detection, but also triaging and differential diagnosis, but more importantly, prognostic information, including prediction, monitoring, response in the use of patient management. And of course, surveillance and detection of resurgence, which is expected. The uniqueness is, of course, that it creates an accessible, comprehensive resource to address topics that no single existing archive could enable independently. The emphasis is on quality. Sure, there's security, access, and sustainability, but with the physicists behind us, we're going to make sure there's quality in what we're doing as well. The collaborative investigators will conduct interdependent and synergistic science, which will enable innovative technical resources for public dissemination, and translation from scientific findings to clinical benefit will be one of the central themes of MIDRC. Another unique goal is that they already have FDA and industry linked in their formative days, and they hope to use these partnerships to catalyze technology and implementation, which is very important because one of our new goals is to expand commercializability of many of the scientific and technological develops that we sponsor. And it's clear from this week's article, it shows that there'll be at least a 3.5-fold increase between now and 2024 in the clinical medical imaging aspects of AI. Now, we all know, I think there are many physicians in the audience, that although their initial respiratory manifestation was what we all focused on, that COVID is beginning to become a disease, a systemic disease that affects the heart, liver, kidneys, obviously neurological, and the pulmonary we've seen, and hypercoagulable and hyperinflammatory states. So what I'm trying to get at is that in the process of accumulating all these images, it's not going to be just about the lungs, but it'll be about all of these other organs that are affected. And in the process of doing so, we will also learn about the AI aspect, or expand upon the AI aspects of what's already being done within this resource center. The indicators of success, I just sort of throw up here, but Goying is going to actually go more into detail. And I want to leave you with this message, that this is not the end of it. This is actually a 2-year contract that was given to the University of Chicago, which is the legal entity behind MIDRC. It's 2 years, $20 million, I believe. But the important thing is that by the end of this, we will have a resource that is prepared to manage future pandemics as they come, and future public health problems, and also to include other organs and organ systems. And we will be looking for ways to sustain it beyond the 2 years.
Thank you so much to Shahid and Chris for that very thoughtful introduction. And Chris has talked to you about many aspects of this very important publicly available resource from NIH. I am very excited today to share to you about 2 things regarding this MIDRC initiative. So I'm going to first talk about some specific goals and objectives of this resource center, and then move on to some scientific structure and show you about different components of this center. So as Chris has highlighted, the overall goal of MIDRC is to move from data to deployment and hypothesis to discovery. And of course, the overarching goal is to accelerate the creation and transfer of innovations and knowledge for clinical management of COVID-19 and possibly for future public health crisis, as Chris mentioned. For the issuing of this contract, what are we going to get? We are going to have a publicly available data resource, which would contain a minimum of 10,000 curated COVID-19 chest radiograph and CTs, along with the associated clinical data, and of course, the annotations. We will have 23 institutions all working together within this funded MIDRC umbrella. We will have 20 research groups engaged using the MIDRC data portion or data repository as a resource to help them when they develop their own machine learning AI algorithms and models, using this data to develop, test, as well as verify and translate in order to develop the methods into products, so which can then be get into the hands of healthcare providers, such as you all. So we will publicly disseminate COVID plan to address pressing COVID-19 questions. And although this within the first 3 months, it's going to be very preliminary, but the questions such as addressing detection and diagnosing, prognosing, predicting the next resurgence, and monitoring the curve of response, and monitoring patient response to various therapy. And the center will engage the FDA and at least 5 industrial collaborators with a goal to really at the outset start thinking about translation, commercialization in order to broadly disseminate the results and the tools. The objectives at the end of the 2 years is that we will have a massive data repository that would be made publicly available, and we'll have in this data repository at least 60,000 curated COVID-19 chest radiographs and the CTs, along with the associated clinical data annotations, as well as images of other modalities and other organ systems that are known now, to also affect by COVID, such as the heart, the brain, and the MSK systems and organs. So we will expand from that initial 23 involved organization, adding 30 more institutions that actively be collaborating with MIDRC and as part of this umbrella. We will also enable 200 research groups that using the MIDRC open platform to tap into this, test their models and development, test their new idea, and honestly, anything, hypothesis that they may have, they need data, and in addition to the AI, machine learning, computational algorithms. And we're engaging, more with the FDA and more industry collaborators to drive really the commercialization and dissemination aspect of it. And we'll demonstrate through 30 COVID-19 related machine learning products on validation and translation, and put them into the FDA pipeline. So this is the distribution of the currently involved 23 institutions under MIDRC. As we move forward, we will expand across the nation and across the medical imaging community. And we envision that anyone in the medical imaging field will be one way or another part of this initiative or part of this effort. So what set MIDRC apart from all the other databases are, I would say, primarily the following, so which I put on the slide as MIDRC characteristics. Large scale, which is self-explanatory, and diversity and quality. So when I say diversity, it means that MIDRC will put effort from the outset trying to reach out, to all the communities and ensure that the data we get appropriately represent the demographic and racial and ethnical representation or distribution of our nation. So we know that minority groups and underrepresented communities have affected by COVID and also being infected by COVID differently, and their response to various therapies are different as well. So we have to put all those into consideration and also consider the possible clinical complexity as well. So the diversity really means, putting all those into consideration from the very beginning at the designing stage. So quality, when I say that, it means not only imaging quality, but also informatics quality, as well as clinical truth quality, to really, make sure we have a robust database that is quality assured and quality controlled and harmonized, linked to the real world in order to help our medical community, help our patient at the end of the day. So, and how do we achieve that? This really is an ambitious goal. So expert collaboration, community engagement, and thoughtful design. It is important to know that MIDRC is not just a database. It really has two major components. The first, of course, is the foundation. So that is the open discovery and data repository. It is about the creation of this data repository, testing it, make sure the quality to ensure really the ultimate highest quality of a database, and ensure data connectivity and accessibility, so to reach as widely as possible, to all the corners of our nation and to the hands of the users and who can then help our patients. And another important component is the data science aspect of it. It's about the use of this repository. Of course, when we say that, it primarily is about AI, machine learning, and for people to tap into the database to develop and testing and translate clinically relevant algorithms and software tools. And here I suggest clinically relevant aspect of those software tools. So then those tools, can be incorporated and integrated, to other devices where healthcare providers can use that, and even our patient, can use those software tools for monitoring and even at someday, in their homes, but initially will be at the hospital and with the radiology department. And to go into a little bit more detail about these 5 projects, this is really the bread and butter and the core research projects, and each led by one of the 4 organizations. As you can see, AAPM is leading the quality assurance, quality control aspect of it and evaluation. So that's TDP 3, and U Chicago's Gen 3 were developing the world-facing data commons portal. And all 4 would work together to link with all the other data registries, including trying to get clinical data associated with COVID. So that's really is a linkage to all the other data systems. So I'm not going into the detail about those 12 collaborative research projects, other than saying that this part will grow. So this is a chart shows how does it work. I would draw the audience attention to the bottom of this chart. This really is, how data flows from the healthcare organizations where patient goes so the data intake is from here, and then get into this virtual registry, and then go to more staging, quality control, and the data integration and review, and etc. And then here is a little bit more of the component of enabling evaluation and the common data model, of course. And here is the linkage, as I mentioned, to all the other data registries, mostly clinical data. And this part is mostly, medical imaging data, as mentioned. So on the top row is really the list of how you can possibly use the data. It's the data application or the data science aspect of it. And then on the top is the users. And I would say when we say user, it's really the public and academic, industry, government, including FDA, and for validation and commercialization eventually. So, so with that, I would like to conclude by saying that this national resource will enable researchers to address topics no single archive could yield independently to help combat the COVID pandemic and possibly beyond. MIDRC is an important public-private partnership that has 3 features: expert collaboration, community engagement, and thoughtful design to ensure quality and public accessibility. So we are very excited about this new center, and we're excited about its great potential to bring real value, for rapidly addressing our nation's public health crisis. I thank you for your attention and for this opportunity to speak with you.
Welcome, Gwen. Thanks for turning on your video. If you if you look at what the MIT team was doing, it was actually, the MIT team didn't do it. It was Beth Israel along with Phillips, who published on MIT Review, I think. So they had access to the MIMIC2 repository, which is about 300,000 images, reports, et cetera. It's a public use data set that has been around for a number of years. Many people know about it, but a lot haven't used it. I was curious, when you think about what MIDRC will be doing, do you feel it is more about infrastructure and allowing others to then use the infrastructure that NIH is doing? Or is it more about bringing people to the NIH in order that they do their research and other things on NIH platforms? Which of the two do you think describes MIDRC more?
Well, there's several data sets like MIMIC, and of course, MIMIC may now be looking at COVID as well, but this was about heart failure, which would be of interest for us at some time. And it's not that patients don't get heart failure in addition to COVID. In terms of how we could link up, they would be part of those large repositories that MIDRC intends to link with. Okay, so the idea, and Going can elaborate on this, is to have as many of them come through and be available through MIDRC. It has its own resources, but eventually to build up more. But we don't have specific NIH grants we are giving out now in terms of MIDRC. We do intend, there's several other ways of funding it if they want to use MIDRC as a resource for their research. But being that MIDRC's only about 2 months old, we're still getting there. So
Got it. And going, so talk a little bit about, you mentioned the 5 main areas where MIDRC is going to help, open discovery, real world testing, quality assurance, data intake, and linkage. To me, it seems like, so AI and ML in the modern era has an insatiable appetite for data, right? Because otherwise ML and AI don't work. So are there one or two of those 5 areas that you are focused on more? And if I could talk from the industry perspective, the data quality assurance and data intake would seem to be 2 areas of more urgent need than some of the other ones, such as linkages, et cetera. I think the linkages will be helpful. As an open discovery platform, maybe it might be helpful, but it seems to me that the data quality assurance and evaluation would probably be the top area. Does that jive with what you guys are thinking as well? Or do you hear from the community different priorities?
Yeah, I would agree with you. And although I think, all 5 areas are important, you have to start with, start somewhere. So the first one is really, the intake, trying to get those data.
Mm-hmm.
And then once you have them, then you make sure, you have to make sure the quality is there. And even safety is, something that we have to pay attention to as well. So as you said, the linkage and accessibility happen after. So after you curated them and you make sure, it's harmonized and meet the industry standard. Mm-hmm. So I think I would say you are right. So what sets MIDRC apart from most of the other bases are that quality really is important. It's not something that we get data there and just say, okay, go play with it. It's really something that we want to take care of, to make sure the quality and safety and accessibility are to the highest standard.
No, that's great. And you mentioned safety a couple of times. Could you elaborate on that safety, Chris, or going?
I'll echo what you just said. I mean, when you talk to the MIDRC principals, it's all about quality. I mean, we all talk about garbage in, garbage out. They don't want to lose the quality. There will be high quality provenance of what's happening, because we're talking about so many repositories. And so what Going says is very much true. We're hoping, and that's the wish, that this will be the distinction.
And in the architecture, you mentioned the common data model and the quality and evaluation happening on that common data model. What is the current status of that common data model? And is it coming from somewhere, or are you guys creating it net new as part of MIDRC?
So, MIDRC doesn't do that from the scratch. As you know, AAPM has been one of their strengths is data quality and control and evaluation. And ACR and RSNA already have been putting effort in database. So it's really build on those efforts and then bring everybody together. So it really is bring the community together and have a concerted effort and a harmonized approach to the data issues.
Yeah, one of the things I would suggest, Chris, and Going is for NIH and maybe as part of MIDRC to come up with a scoring capability for incoming data. So, for example, if you had data minus report, it would be 1 score. If you had data with report, it would be another score. Data with report properly coded would be another score. And so if we got intake, and then it would be interesting that if you had different participants, if you got 30 up to 60 institutions over the next couple of years, they're all going to be at different scoring levels, right? So that would be, if you're still open to input, taking that and saying work as you build the common data model, work on the scoring for the incoming data sets so that the quality and the evaluation and the labeling becomes that much easier. So is that something you've already thought about? And we've got about 2 minutes left before.
Yeah, definitely that there's going to be some level of that. Just knowing how the physicists work in the area. The other thing, alluding to your earlier question, the NIH is already, through the clinical center, has contributed several hundred cases through the TCIA, the Cancer Imaging Archive, which is the starting archive, to the MIDRC effort. So yeah, we're also adding to it, as others will. But I'll let Going take the last few minutes to answer whatever she wants to.
Yeah, I think what you said about giving a score, that's a great suggestion, and I think it's something that we're thinking about. And at this point, MIDRC is thinking about designing the common data elements to including, to try to really get all the data and all the information, where, the patient live and what the socioeconomic, status and the race, ethnicity, and everything, about, the patient. Of course, we have to make sure, the security and the confidentiality, all those things are, satisfied. So that's part of the area. We really want to have those rich, data set, and while, at the same time, ensure the highest quality. And then giving some score, evaluate those data is, part of the process.
Now, this is very exciting. I mean, I see what you guys are doing for diagnostic image-based machine learning, what the internet allowed us to do with commerce, right? If the government had not funded the infrastructure for the internet, the rest of us couldn't do what we're doing today. And that's what MIDRC is. It's an opening salvo, but a very, very important one. So we are thrilled to have you here, and hopefully you'll come back at a future Health Impact to give us a status update. And if you need any one of us to participate in common data model scoring, et cetera, don't hesitate to reach out. With the audience, thanks for joining. Yeah, go ahead, Krishna.
Just one brief comment. It's not just about imaging. It is also associated clinical data. That is very important. Yeah. Okay.
Great point. Again, thank you, Guang and Krishna, and we'll have you back in a future episode. So for the audience, please go back to your agenda, hit the button to join the next session, and we will see you there. Thanks again, guys.